It's a home run.
Welcome everyone to the second in the webinar world series for On the Mend, which is looking at digital health in physical rehab and asking, is this a home run? So in the US, which is at the forefront of adopting digital rehabilitation, there's no better place to continue the conversation from last week, where we were looking at the future of physical rehabilitation with UK-based physiotherapy teams. And today we are fortunate to be bringing together two leading voices in their respective fields in orthopedics and in home health, joining me to explore the impact of these innovations and to try and identify what is needed to accelerate adoption and also improve outcomes for patients. I am Wesley Fogel. I am the co-founder and CEO of On the Mend. It is a remote therapeutic digital platform making physical rehab more motivating, personalized, and data-driven. And I am very pleased to introduce our two panelists today. We have Brenton Pennicooke, a board-certified spine fellowship trained neurosurgeon and assistant professor of neurosurgery, orthopedic surgery, and biomedical engineering at Washington University in St. Louis, specializing in complex spinal reconstruction and minimally invasive spine surgery. And his research uses artificial intelligence and machine learning to improve patient outcomes. We have David Bell, is the chair of GrandCare Health Services and the CEO of IO Health Tech. Dave is a seasoned leader in home health innovation, having led GrandCare to a 5-star rating for in-home rehab and developed IO Health's award-winning intuition platform. His focus is on streamlining operations and documentation through AI-driven tools that improve care quality, reduce administrative burden, and enhance financial outcomes for home health and hospice organizations. So as I mentioned, today's session is about digital transformation in US rehabilitation, but it's not just going to be an abstract discussion. We're going to ground that transformation in the realities that clinicians, operators, and innovators like ourselves face each day. And we're going to try and focus around 5 key themes that are shaping the future of rehab in the US. So that's remote therapeutic monitoring, insurance and reimbursement models, AI and data-driven rehab, the barriers to adoption, and the future innovation and opportunities. But I also want us to try and surface some of the tensions beneath these themes. So where innovation is meeting resistance, where policy might lag behind technology, and where AI promises might be colliding with clinical realities. So we'll try and explore what's working, what's not, and what needs to change. So I'll just try and open each theme with a few framing remarks and questions, and just invite our panelists to respond and make space for dialogue between them, and also try and leave time for audience Q&A. So thank you to those who have joined so far. So with that, let's dive into the first theme, which is remote therapeutic monitoring, where rehab is going beyond the clinic walls. And we see remote monitoring as increasingly used to track patient progress and improve adherence to rehab programs. But integrating these tools into clinical workflows does present operational and regulatory challenges. So my first question to you, Brenton, I will kick off with you, is firstly, how you see remote monitoring enhancing physical rehabilitation outcomes for your patients. Thanks.
Yeah, thank you, Wesley. Thank you for the invitation. I think for me, the way that I've seen it work best for my patients is really an accountability thing for them. You know, when I've used similar digital platforms that they can work and do physical therapy with, or have daily prompts to walk or daily prompts to do certain motions and get moving. What it allows me to do as a clinician is when I see them at their 6-week follow-up or their 3-month follow-up, I can literally pull up what their activity has been over the last several weeks and talk to them about what worked well, talk to them about specific days maybe where they did not move as much, and really give them some guidance on how to kind of keep moving. And that's how I use it in my practice. is really postoperative accountability, but also motivation. I have found, I'm sure you'll bring this up later on in our discussion. The biggest thing is my patients that are very self-motivated, they use these platforms very, very diligently, and you almost don't have to, prod them or do anything. Like they want to do it, right? They're logging in. Even if you had a reward system for a lot of these digital platforms, they want to get every single award. And it's not even the reward itself that is incentivizing them to use it more. It's just who they are and how they are. And I think a lot of patients like that, almost irrespective of what was done, they were going to do good rehab postoperatively. I think the biggest opportunity for these platforms are kind of not necessarily the laggards, in terms of patients, but the people that don't necessarily have that intrinsic motivation to do certain things. Like sometimes they do need their provider to be kind of pushing them to do these things, or they do need that reward system within the digital platform. So I do think that that's probably the real opportunity. But again, I use it for my postoperative patients, and at least thus far, they've found it very useful.
It's interesting, Brenton. And Dave, from your point of view, integrating remote monitoring into home health, how has that worked in the organizations you've worked with?
Yeah, so I run a group of home health agencies, and we care for about 10,000 postoperative orthopedic patients per year throughout Southern California. And most of those patients are associated with bundles or some other kind of at-risk program that seems like on the surface it would be a perfect environment for these kinds of systems to succeed. We've encountered a lot of challenges. I mean, obviously we've had a lot of patients, like Dr. Pennicooke said, that use them just on a self-motivated basis. We also have individual doctors who encourage their patients to use them, but we have yet to see a kind of program-wide system work very well. And we've had several that were tested. The challenges, and I'm maybe skipping ahead, but there's several challenges that are blocks to that happening, and we can get into that in a minute. But we've had experience working with app-based systems. We've had more like kind of text just to make sure people are doing their thing based systems. We've seen RCM devices that were tech enabled and connected to the internet type approaches, and we have not seen any that succeeded, not because of the merits of the device itself, but because of the environment and the payment structure, et cetera.
Yeah, we'll be coming to the payments side of things shortly, but I think before we touch on that, the kind of infrastructure that needs to be in place to make this a scalable solution, what do you think is currently lacking to make this work in a decentralized model like home health?
You want me to start with that, or?
Yeah, I was going to ask you to follow on. Yeah, please do.
Yeah, sure. So, if it involves equipment like the tech-enabled RCM machines, for example, then what we see there is that you've got to deliver the thing, you got to get the thing back, and there's a lot of logistics around that. Home health agencies are not set up to do that. Deliver 50-pound devices, which is what the devices we were working with were. Which is just that creates a whole bunch of OSHA issues. We're going to end up with all of our clinicians getting back surgeries themselves if we do that. So that there's that. There's just the logistics of equipment. There's also the logistics of getting people to install software. So in general, our population who receive these kinds of surgeries tend to be over 65 on average, and so all those people are at this point pretty comfortable with sending and receiving text message, or not all, but a large fraction. But when you want to get them to install software on their devices, we found that that's pretty challenging. I mean, we've had maximum of about 50% success rate. People have old phones, they have old versions of operating systems. they just don't know how to do it. They can't remember their password. Same issues that somebody my age would have, but at a higher rate. And so I'd say those are the main infrastructure and logistics related challenges that we faced.
Interesting. Brenton, how much of these problems do you think starts at the home, or even before then? Do you see these issues in the hospital when you're treating the patients?
Oh, for sure in the hospital. I mean, I think the best, I would say more advanced electronic or digital platform that I've seen for patients are things that connect directly to the electronic health record, like MyChart, right? My older patients are very savvy with MyChart, like, sometimes a little too savvy, right? They're sending messages and, it's almost, too much access sometimes. But that is clearly integrated with their workflow. It's an app on their phone. A lot of people have, Apple phones or smartphone, know how to use smartphones. And so it can be done, right? And I think how it works really well, at least in my clinic, is we basically, as soon as the patient comes in to see me, we have them sign up for MyChart because we think that it helps facilitate communication, right? They can see my note, I say a lot in my clinic visits, and I leave pretty extensive notes, and there's a lot of information that's being fired at the patient at once, and it can be very overwhelming. And so by the end of the conversation, I say all this is going to be written in a note that you can pull up on your phone and read. And if there's anything that you don't recall or you disagree with or any, send us a message and we're happy to modify. But really what the EHR is a record of this interaction. That's what this is. And I think a lot of my patients, especially my older patients, really like that. They'll pull up their chart at the dinner table and talk about, what the surgical plan is. And then, the next time I see them, be like, yeah, we spoke about it. So it can be done. And I think it does start at kind of the first patient interaction. It can start at the primary care doctor's office. It can start at even the specialist's office. I do think that I somewhat benefit from the fact that, the hospital system that I work for is a very large hospital system. And so it kind of has a bit of a bully pulpit in that it has a lot of patients that they basically force to use one EHR. That's not the case across the US, right? Everybody has their own EHR. Most people use Epic, but some people use Oracle system. There's all sorts of different things that don't talk well. And so because things are so fragmented, that can be challenging. But I think for a challenge for your company, Leslie, and other similar companies is if you start at the point of care, like whichever the physician is who's seeing the patient, and have the patient sign up then and have it be a way of basically, this is the start of your journey. You're signing up for this app. That's the way you kind of allow it to migrate through the progression for the healing of the patient, I think.
Got it. And Dave, how much are you seeing of that consistency for the patient going from clinic to home and feeling like there is less fragmentation in the market, or is this problem getting worse?
Well, we operate in the Southern California metropolitan area, so we do see that fragmentation that Dr. Pennicooke is talking about. We deal with a lot of EMRs, and that is a challenge for us. And not only do you have all these EMRs, but you got all the systems layered on top of them that people use. That said, I agree 100% that when the doctor drives it, when they hear it from the doctor or they hear it from the discharge planner in the hospital, when they hear it from somebody who, they perceive as an authority related to the hospital, then, adoption is much, much easier. We just say, hey, Dr. Oakes tells us you want us to do X, Y, and Z. And, that's much, much easier for us than situations where we're trying to get them to do something ourselves. I mean, we still get compliance, but we find, the best practices prior to surgery, the doctor's talking to them and saying, hey, look, surgery's hard, I'm going to need you to do X, Y, and Z in order for you to have a successful outcome. And people take that very seriously when they hear that directly from the doctor. And that works in our experience.
Yeah.
Makes sense. Brenton, anything further to add on that subject?
Um, I would say, even I use my chart as the example. I think that is one system that seems to work very well, even for patients that aren't particularly digitally, literate, we'll call it digitally literate. But even for them, they still, some patients still need some like hand holding, right? Where they really need somebody who helps them sign up in person. And so I think most of these systems work well when a lot of make it kind of very streamlined, almost idiot proof, but have the redundancy in place where someone can still help someone who needs that extra, assistance. When and make sure that all the glitches and bugs are out of the way before it's kind of rolled out. And I think that's important because a lot of the patients that will sign up for these apps, they don't necessarily want to do it. They're kind of doing it because I'm telling them to do it. And so as soon as they get like a micron of resistance, they're like, all right, I'm good. Because then they're going to come back to me and be like, well, how much do you really need me to do this? And I'm like, well, it's a nice to have. It's not, I wouldn't necessarily classify as a need to have, at least right now. It may get to a point where it's a need to have. And so once they get that little bit of resistance, they're like, I don't want to do it. So just working out the bugs and making sure that there's an actual human who can help usher people through signing up and how to use the application.
Understood. I think we could probably talk the whole hour about this subject, but I think the one I'm trying to get to is reimbursement, because nothing is really viable unless it has a reimbursement model associated with it. And I'm trying to understand, maybe Dave, you could start from the home health in terms of how different reimbursement policies have affected the adoption of digital tools.
Well, I mean, I'd say that, from the home health perspective, the reimbursement policies are the primary obstacle to, success. So there are two problems. So the first is we can't get paid for any of this. Now there's kind of a workaround, which is that we can do most of the work on behalf of the doctor and then having a relationship with the doctor where we get reimbursed. We get a portion of the reimbursement that would go to the doctor. Unless you're very careful, that raises Stark Law compliance issues and inducement issues, which could be a whole nother webinar. But so we but even then, the amounts we're talking about are $50 a month per patient or some number like that. Now, there's also a separate problem, even then, if you resolve that, which is that the way Medicare rules work, and for us, everything we do has to be compliant with Medicare rules, even if a large fraction of our patients are non-Medicare patients. So the problem we have is typically these post-surgical care plans for knee and hip patients are 4 visits, 5 visits, 6 visits. They might last a week and a half or 2 weeks. Spine patients could be almost anything from that sort of range up to a few months, depending on what's going on with that patient. But in our world, everything gets reimbursed on a 30-day period basis. Once we have discharged the patient, we are not allowed to do anything for that patient, including post-therapeutic monitoring, or at least we're not allowed to get paid for it. So there's this gap between when we discharge them and 30 days. After that, we can do it. So the way Medicare reimburses us, first of all, doesn't cover remote therapeutic monitoring, and in some ways prevents it. Similarly, we're penalized for doing anything before the surgery, also, including getting them set up so their devices have the software installed. Again, there's workarounds, but what people have been talking about for 10 years now is Medicare right sizing or fixing these rules so that they align our interests with the interests of the doctor and allow us to help in this way, because we're face to face with the patient a lot currently that has not been addressed, and it's a major obstacle.
Well, we can try and align with the doctor today. We have one here. So let's talk about how is reimbursement affecting the way you use these tools, Brenton?
So, frankly, the only reason why I'm able to use them is if I have an agreement with a company that allows my patients to use them without charge to them. So that's just a very gracious company eating the cost, right? It's presumably there's some incentive on their end, but that it's cost being eaten by a company, or finding a patient who's willing to pay for it themselves. And that's a rare patient, frankly. And so I did have a thought of like trying to get, some of the physical therapy offices in the region to do it themselves. And to the point that David Bell brought up is like, they're like, well, how do I actually get reimbursed for this? So everybody thinks it's like a great idea, right? And monitoring, but they're like, all right, well, where's the revenue going to come from? And in preparation to this webinar, I was like trying to research some of the new CPT codes. There are new CPT codes for, remote care that came out in 2022. There are opportunities there, but nobody really knows how to like work the revenue cycle of these things, right? And so unless you really have buy-in from a physical therapy office, or even, there's no reason why my office couldn't do it. I mean, I'm not a physical therapist, but I do know generally what is good in terms of monitoring in the immediate perioperative period, right? And so even if my office, if I had a biller who I said, all right, we're going to set our patients up for these things, this is how we're going to bill it, I don't think I could, right? Because it's in the 90-day global after a spine surgery. So I wouldn't get paid for it anyway. But if there was a way to like actually out after the 90-day global or something like that, truly have a nice revenue cycle of, having these patients that continue to do kind of maintenance therapy remotely, that'd be a nice thing to do. But honestly, nobody's really put effort into it. Like, honestly, on the physician side, we're so focused on how much our reimbursements gets cut year over year for like what we do that we're not as much worried about like pushing the envelope for new opportunities. But I do think there's a wonderful opportunity here that benefits patients and would benefit providers as well. It's just nobody wants to do it. They're, at this point.
Yeah. Dave.
Yeah, I would, Wesley, if I could jump in on that, I would just say that I do think I don't run any outpatient clinics, any therapy clinics, but my understanding is that, they operate under the Medicare Part B rules. We operate under Medicare Part A rules. And under Medicare Part B rules, my understanding is that they do have the opportunity to bill for this. Now, the problem is it's a very high number of very small bills. So there's a relatively large amount of work that they need to do to get it. It's something new they need to learn. So I'd say that to the extent that the RTM companies can make it built into the process so that billing is painless for those folks, that's helpful. The groups that I've seen that seem like they're the most successful at it and really lean into it are situations where a surgeon or, typically a group of surgeons also is associated with a clinic. Often they're co-located. And in those situations, they do the surgery and then the patient does outpatient there. And I've seen them really wrap their heads around that because, to your point, I think they can bill during that 90-day period because it's that separate clinic doing the billing.
Interesting. Yeah.
Mm-hmm.
Well, could I just widen the lens a little bit and maybe Dave just ask this firstly, like how the payer sees the value in these digital tools and maybe how you think they should see the value in understanding the right way to reimburse them?
Well, a lot of conversations about payers, the difference between what the value they see and the value they should see are not necessarily the same thing, right? Our day-to-day reality when we're negotiating contracts with payers, we're trying to get a claim paid. We're dealing with people who are rewarded and reimbursed on the basis of minimizing costs, and they're typically their goal is to minimize cost per visit, cost per episode, whatever that is, and they're typically not the people who are 2 or 3 levels up the ladder who have the bigger picture of, hey, this might be more per visit, but it's going to save money overall for the program on a population basis. We have found that those conversations are surprisingly hard to have, even when you have solid data to back what you're doing, because and if you're dealing with, let's say, a TPA, which we often are, a third-party administrator, who is basically doing the billing and collecting and contract negotiation on behalf of a payer. They're 100%, their entire business model is on a per visit or per episode basis. So you can't even have that conversation with them. So we found that finding that alignment has to be strategic and has to happen at a high level. What we often encounter there, and I'm curious what Dr. Pennicooke thinks, but what we often encounter is that when you go and try to have those strategic conversations about RTM in particular, they say, hey, look, when you look at all the things that move the needle for us, orthopedics are way, way, way down the list of things we care about. These are cheap, small, relatively, even though it's a big part of home health, and even though it's a big part of, something that many seniors experience during their lifetime, the costs are much smaller than the chronic conditions that, which really eat up big pieces of their budget. So they're much more willing to have conversations about something that controls chronic conditions, and they're much more open to value arguments there than things that are short episodes, in my experience.
Yeah. That's a great point. I think most of we on the provider side, I almost never get a denial for like postoperative physical therapy or even preoperative physical therapy. I mean, Medicaid will deny it depending on what you use for the diagnosis. But it's not really like a big hurdle for a lot of the payers, because if it was, I'd be doing peer-to-peers, to justify, why I think this intervention is indicated or warranted. So I just think it's not high on their priority list. I think for me, the things that they put a lot of value in is my length of hospital stay, right? They really don't want patients staying in the hospital a day longer than they have to, not even, a day. And the other thing that they'll give a lot of challenge with is imaging studies. So, why this imaging study versus another. And then the third thing that they'll give a lot of challenge to is surgery itself. Like, yeah, is this surgery indicated? Has the patient done the proper treatment course or paradigm of treatment before you even got into surgery? And I think that that's because a lot of those things, whether it's hospital stay, imaging study, surgery, they almost create this cascade. I'm a spine surgeon, so if I do a fusion, it's almost a near guarantee that over the course of your life, unless you're, in your last year of life, you're probably going to have another one. And the younger the patient is for fusion surgery, the higher the likelihood that over the course of their lifespan, they'll have another one. And so, and the insurers know this as well. So the single most cost-saving thing that they can do is prevent that first spine fusion surgery, right? And it's probably costs less to do that than 15 years of physical therapy, right? In-person physical therapy. So if if your product is based on just kind of cost savings and it's in the kind of the translating what was done in person to now being done virtually. I think the true cost savings for a lot of these insurance companies, it's not something that's very tangible for them.
Dave, does that resonate with you?
It does. And, you know, one additional factor that I would throw out there is there are a few payment models, and Medicare is one of them, that, you know, takes responsibility for a patient for a long period of time. But most US healthcare is annual. And so, you know, spending an extra $10 now to save me however many dollars, it doesn't matter, next year or the year after that, is just not relevant to many US healthcare plans.
Interesting.
Yeah. It's interesting. Again, like this could be a subject we can delve into and explore further. I'm keen to kind of continue into other areas if that's okay. I'm also seeing there are people in the audience. If they do want to ask a question, please feel free. But I will take the liberty of moving us seamlessly into a discussion around AI, which, if we're looking for solutions to problems, people seem to think this is an easy one-hit wonder. But we'll see at the end of this section. So I guess the question of how AI enhances not just the way care is delivered, the personalization, the outcomes and the pathways that are designed around this. I mean, for you, Brenton, firstly, like how you see data and AI making pathways more personalized around patient needs.
Yeah. So clearly this is a topic that's near and dear to me. I mean, I was enthusiastic about artificial intelligence before it was even became this buzz of artificial intelligence. I was in the era where everyone was talking about machine learning, and before that it was all about predictive analytics, and before that it was just statistics. You know, it's like it's so interesting. But anyway, so how I use it is a lot of how I practice is clustering of patients, right? Generally speaking, I know before scalpel hits skin, the likelihood of certain outcomes. And I generally know a range, and a lot of it is, it's not a specific number, you know, per se. It is, I know a person with these certain features, these certain characteristics, the likelihood that they're going to be discharged to a rehab or discharged to home based on the procedure that I plan on doing. I know the likelihood that if I do one operation versus the another, the likelihood that I will be doing another operation in the next 6 months. And I know that for me, for my practice. I know it generally for other surgeons, but I know it for me because I track it for myself. I find it very useful for counseling and setting expectations for patients, right? Especially because of the field that I'm in, you know, most of the people that I'm operating on are seeking pain remedies, right? And, you know, spine surgeon can certainly help people who are in pain, but it's not really like the magic bullet, so to speak, for pain syndromes. And so a lot of what I do is counsel, advise, provide logic, rationale, data for people to make their own decisions. So that's where AI, I think, can be very helpful, right? Because it can provide the framework for that logic discussion and that rationality. The emotions and the actual influence, that has to always come from a physician, right? I mean, even with like ChatGPT now having like different inflection and how the voice is, you know, used, and, you know, being a little bit snarky and all that stuff, like that's not, it's still a computer, right? At the end of the day, or an algorithm, at the end of the day, the emotions of how the logic is conveyed is always going to come from a physician. But actually creating a framework for that discussion, AI is very useful for, right? It streamlines it, it makes it easy, right? Where, you know, literally any physician could plug and play if they had the right infrastructure, right? Age, comorbidities, what surgery did you have planned? All right, well, this is the likelihood the patient's going to go to rehab based on a large population of people. This is the likelihood that they'll have, you know, a greater than 3-point improvement in their pain scale. And this is the likelihood that they'll be back in 6 months for another operation if you do this one. I think that's like very basic level AI, and it's just how the tool is used by physicians.
Interesting. Dave, I'd love to get your thoughts on that. I was going to ask about how you've seen AI in workflow efficiency, but maybe also just reflecting on what Dr. Pennicooke said. Oh, and you're muted now, Dave. I don't know if it was muted.
Yeah, sorry. Many of the things that you mentioned are items that, you know, we do, but, you know, from the perspective of the post-acute provider. So we do many of them in partnership with our doctors. So in some cases, you know, it sounds like you're very tech savvy. Many of our doctors are not tech savvy, and you know, they need or appreciate help. So, you know, one of the things we can help with is trying to triage which patients, you know, are likely to benefit from, you know, certain types of care. We are more focused on knees and hips in that regard. Spines are pretty complicated, so I think you know, that's an area we haven't gotten into yet. But you know, so based on all the various risk factors and demographics, one of the things that we do is we look at recovery versus a risk-adjusted baseline, and this is you know, again, a machine learning model, so, you know, an AI model, so to speak, that looks at it, you know, is the patient on track or not? And so that we find that very helpful, you know, in terms of, you know, mentioned pain scales and range of motion for these joints, is a good way of predicting patients who are at risk of a negative outcome, or, you know, some other risk factor, you know, fall or some other non-compliance or some other problem. And we have found that we can predict. Well, we can predict better than the clinicians in the field can predict which patients are likely to benefit from some sort of additional intervention to prevent those things from happening. Another thing we do is we look at the pathway, so we can help doctors look at you know, which patients are going to be suitable for a discharge directly to an outpatient clinic versus which patients are going to benefit from a skilled nursing facility, which is very few at this point, or a home health treatment. Obviously, you know, for us, we'd like it to be home health, but you know, our first priority is to make sure that we're putting the interests of the patients and the doctors first. So, you know, if the answer is outpatient, you know, we advise the doctor, hey, this one probably ought to go to outpatient, not to us. So those are the main use cases that we're working with right now. And as you, I mean, at least as far as this conversation is concerned, we do a bunch of other stuff, but you know, and those are every single thing I just mentioned. The models perform considerably better than humans.
Mm-hmm.
Well, on the subject of automation and clinical autonomy, I mean, where do you see that line now, and where do you see that line going? Like, how far is too far? Brenton, maybe.
Yeah. I think that there's always going to be a little bit of nuance to doctoring. I don't think it's going to be, even if an algorithm says, you know, this is the right treatment course for this patient based on, you know, 3,000 different publications that have shown that this is better than something else, or, you know, there's always going to be the element of talking to the patient and figuring out what they want, right? Because I think there's logical decisions, and then there's just straight emotional decisions. Like I have countless patients who have really, I would say countless, that sounds wild, but I have several patients who have really significant myelopathy, cord compression, right? And if you look at any study, it's like earlier the intervention, the better in terms of long-term outcomes. This is very much a surgical disease. This is not something that you can rehab your way out of. And it is something that, you know, generally speaking, you want to address proactively. A lot of my patients, you know, based on what they have going on in life, some are in school, some, are the primary caregiver for their family, and they can't do a massive operation. They have to do something small, right? Just to get them by, protect their spinal cord, and then maybe later on do something more definitive. That level of complexity isn't something that necessarily an algorithm is going to be able to parse out for you, right? Because an algorithm will be like, right, these are the levels compressed based on the data that we know. You need to do like a massive spinal fusion decompression surgery. And that's probably the quote unquote right thing to do, but that's the wrong thing to do for this individual. Because if you take them out of work for 3 months, or you allow it so that they're not able to be the primary caregiver for their family, the downstream effects of that could be much more grave than anything. And so I, I don't think the envelope's going to get pushed too far, frankly. I don't. And that this also could be, maybe I'm naive. But I think people won't allow it because ultimately you're making a decision with a doctor. There's a reason why you don't just like go in and punch in your metrics and it spits out, this is the surgery you get. And then you go to me and say, all right, this is the surgery computer GPT said to do. And I'm like, all right, let's do it. Right. There's a reason. Right.
Right.
And the reason is you need human interaction, a little bit higher level kind of discernment and the emotional connection to kind of know what's the right thing to do for the right person. That's personalization, right? That's what we're all endeavoring to do as providers.
Yeah, I mean, and to follow up on that, first of all, I agree with all of that, and I think the fundamental role is to augment and to check and to offer alternatives, but not to replace the clinical judgment of clinicians. So, I think in our case, we provide a data point that our doctors can take into consideration when making their decisions. And, it wouldn't be appropriate, even if our model in some sense were perfect, which of course it isn't, but even if it were, it's not the only consideration. So, we think of it as, a quality check or an augmentation layer, but not a replacement for, that. Plus, by regulation, these are decisions that have to be made by clinicians. So, I'd say, but Wesley, to your point earlier, question earlier, where is this most applicable? When we're dealing with clinical things, then, our role at best is to advise or provide checks. When we're dealing with non-clinical things, I think, the sky's more or less the limit. Like, so, I think that many of our back office jobs, many of our, med tech jobs, which are really, processing documentation, processing bills, reconciling claims. And I think they're really the more, the better, because, to the extent that you can get it to perform better than a human, everybody wins from that. Payers win, patients win, things happen faster. And those are, and honestly, my workers would rather not spend all day reconciling bills. They would rather be doing, more value add stuff that's more aligned with what they went to school for. So, we focus on those two areas. So assisting with clinical decisions, but not making them, and everything else as much as possible.
To piggyback on that, David, I think we benefit. This hasn't been rolled out by my group or anyone that I know, but in thinking out loud, it's really good at resource allocation. Like, all right, you have two people who need surgery, but one probably needs it faster than the other. Like, which one do you do, right? And I think that is where it is particularly powerful and helpful, and maybe a little bit less of a upsetting feature to the patient. Like if the algo, whatever the algo is, says patient X goes ahead of you, for whatever reason, then you just like blame the algo, right?
Right.
So and it's not like the doctor likes this patient more than it likes me, so it's really good at resource allocation. We face a lot of that with like there are a lot of things that can be treated equally as well with non-surgical management as with surgical management. And far more resources go into surgery than non-surgical management. And so if you have two patients where you basically have this same exact, long-term outcome, it would be good to have a way for AI to tell you, all right, this person's definitely non-surgical. This person probably benefit most from surgical.
Mhm.
That's how I would want to use it, frankly.
Well, is it that there is also missing an AI standard of care, and is it the US, is the US the place to write that standard, or is this a global standard?
Yikes. That was a good question, Wesley.
Yeah.
Right at the
I have
end.
strong
We
opinions
have 2 minutes
about
left.
U.S. healthcare. Yeah, I got strong opinions about U.S. healthcare. I love it. Clearly, I'm American and I practice here, but we also have arguably the sickest population in the world, right? So I don't think that, you know, I don't think there's a lot that's, I would say, is standard here when it comes to healthcare. I think we, as a country, need to figure out how to become less sick as a population, number one, and number two, we need to figure out how to retain or contain costs because it's unsustainable, and soon everybody's going to be very, very upset. So I do think that in that regard, AI would be great to solve this problem in the US, but I think it's a culture change beyond it being a tech change.
Human
Yeah.
change. Dave.
You know what we see in terms of AI standards and regulation in our area is really a lack. There's almost no guidance right now. There have been haphazard enforcement actions against people who were doing things that weren't, considered to be proper, such as getting AIs to make clinical judgments instead of clinicians. But there hasn't been good guidance on that. And one example is, where is that line exactly between providing advice to a clinician and making a clinical decision for a clinician? Is an area that, at least in our area, hasn't, and people haven't even attempted, as far as I know, to define where that line is. So what that means is that people like us attempting to help clinicians find ourselves having to make up our own rules and decide for ourselves where we think that line ought to be, and hope that we don't end up on the wrong side of whatever that ultimately is. We take a conservative approach as a result. Obviously, I think appropriately, but we also are competing against people who aren't taking conservative approaches and are telling clinicians what they should answer for, questions from patients. And I think what's going to happen is that, people are going to get hurt, and there's going to be a reckoning, and then people are going to come out with regulations on this stuff, or guidance or standards, or whatever form that ultimately takes. But right now we're flying blind.
Okay. I feel like I've probably set too many agendas for this call because we have now run out of time. But I do think this has been a really interesting start to a conversation, and I do hope we can find a way to continue it, maybe offline or in other forum in future. But I think this has really been a great way to see the US perspective on digital healthcare, which is why we've run it this way. And we are actually planning a next session next week, actually on Monday at midday GMT. So it's just a little bit too early, 7 a.m. Eastern, but even earlier in the West Coast. But this will be an important one. This is about being joined by patient advocates and understanding what rehab looks like on the other side of the screen, because we're obviously building for patients, but we need to build with them. So that will be next Monday, and obviously we'll share the recording for those who can't make it. But definitely want to thank everyone who's managed to join today. Obviously our panelists, thanks Dave, thanks Dr. Pennicooke, and as for your time. And if anyone has any questions for anyone that spoke today that didn't get a chance to ask them, send them to info@onthemend.com, and we'll we'll pass those on. But yeah, just leaves me to say thank you to our panelists again. Thank you to you for joining, and yeah, wish you a great day ahead. Thank you much. Take care.
Thank you.
Thank you, Leslie.